Hello, I'm Dr. Maury Markman from City of Hope. And in this segment of Minister Markman, I want to continue our conversation of abstracts, highly clinically relevant abstracts published or reported at the recent 2025 ESMO meeting in Berlin. I want to emphasize the studies that I highlighted last time, this time, and final segment next week are both excellent in their design and conduct and paradigm changing. So the study I want to mention today was trastuzumab deruxtecan T-DXd versus trastuzumab emtansine T-DM1 in patients with high-risk human epithelial growth factor receptor 2 positive, HER2 positive primary breast cancer with residual invasive disease after neoadjuvant therapy. These were the interim results from analysis from the Destiny Breast 05 trial. Now, little sidelight here. This is what we're seeing is an evolution as we'd anticipate, or at least as we would hope for, from a first generation, you can call it the second generation, third generation drugs. Antibody drug conjugates have begun to revolutionize our care in a number of tumor types. Certainly breast cancer is very prominent in that regard. But what we're seeing here is a comparison of an established standard of care antibody drug conjugate to a new one and demonstrating superiority. And we can anticipate, I believe, future generations of such novel drugs, novel antibodies, looking at HER2, novel linkages, novel cytotoxins attached that are going to increase efficacy and also, hopefully, very much so, decrease toxicity. So again, background here, HER2 targeted therapies have unquestionably improved outcomes for patients with HER2 positive early breast cancers. Noted that the Catherine trial, which looked at adjuvant T-DM1, that the control arm in this study had demonstrated improved invasive disease-free survival and overall survival relative to trastuzumab in patients with HER2 positive early breast cancer and residual invasive disease after neoadjuvant chemotherapy. However, there were subgroups there that didn't do particularly well. So the idea that we needed to find better therapies is out there, has been out there, and will continue to be out there. It was also noted that there was not evidence that the TDM1 favorably impacted the risk of central nervous system recurrence compared to trastuzumab itself. Therefore, there was clearly an unmet need. In other studies, there was evidence that this newer agent, TDXd, actually seemed to provide superior outcomes in second-line metastatic breast cancer. So in this particular trial, the goal, which is a multi-center randomized open-label phase 3 trial to assess the efficacy and safety of adjuvant TDXd compared to the standard TDM1 in high-risk patients with HER2 positive early breast cancer who had residual disease following neoadjuvant chemotherapy. So that was the design. Study was very well designed. Randomization seemed to be excellent. High-risk population, which I will not go into in detail because it's very specific, but certainly in reading the paper, the abstract yourself, you can look at these details. But these were a high-risk population with residual disease after neoadjuvant chemotherapy. Patients' HER2 status was centrally confirmed in the trial, and various appropriate stratifications were undertaken in the trial. Approximately 1,600 patients who were planned to be entered in the study. The two drugs, the experimental drug and the control arm, were given for 14 cycles, and the primary endpoint was invasive disease-free survival. The bottom line, the primary endpoint was invasive disease-free survival, and at 3 years, there was a highly statistically significant improvement in disease-free survival in favor of the experimental agent with a p-value of 0.0001, hazard ratio of 0.47. And so as noted by the investigators, the use of TDXD resulted in a 53% reduction in the risk of invasive disease recurrence or death compared to TDM1. When one looked at a variety of endpoints in terms of, was there any difference in this? There wasn't. All the various groups that were looked at, various subset were looked at, all of them benefited from the experimental agent compared to the standard of care. So in conclusion, the Destiny Breast 5 study demonstrated a statistically significant and clinically meaningful improvement, and I would agree with that conclusion, in invasive disease-free survival and overall disease-free survival with TDXD compared to TDM1 in high-risk patients with HER2-positive early breast cancer with residual disease after neoadjuvant chemotherapy. Benefit was consistent across all pre-specified subgroups, and it was noted that CNS metastases and deaths were numerically lower with TDX1. That's as far as they went, numerically lower, no comment on statistical significance. And the overall safety profiles were similar in this study to what was known about the drugs. Very specifically, if one looked at drug-related interstitial lung disease, it was reported in 9.6% of patients receiving TDXD, approximately 1 out of 10, with the majority of these being grade 1 and 2 and reversible. Clearly, this is a significant side effect. It needs to be watched very carefully when you're using this agent. But again, this study clearly demonstrates improvement with the experimental agent, and this should certainly be considered moving forward as a standard of care option in this clinical setting. And I thank you for your attention.